How these are structured is that you have screening. This is for the clinical trials in particular, but you start with the screening to make sure that someone does not have any contraindications, and we'll talk more about what those are in a minute. And make sure that they're a good candidate to do this. And then you have preparatory sessions. This whole protocol is 18 weeks long. This is MDMA assisted psychotherapy for PTSD. That's what we're looking at here. And so you can see they've got 3 preparatory sessions. Then you have the first MDMA session at 80 milligrams, and then 3 integration sessions afterwards. And integration, so preparatory sessions are where you really get someone ready for the experience. You really work on that set and setting. You work all the details out. And then and also, of course, talk about what they're there to work on, to talk about the trauma, talk about the stuck points around the trauma, really set that intention for what do you want to work on in the MDMA sessions. So then you've got the first MDMA session, followed by what are called integration sessions. And integration sessions are where you talk about what you experienced in the MDMA sessions. And there's often a lot to talk about. Again, the duration of the experience itself is about 6 hours, depending on the dose, maybe a little bit less, with that peak experience happening for maybe about 2 of them, but you could experience a lot during that time. So, and these are, of course, with licensed, trained therapists. So, master's prepared or doctorally prepared therapists, which is an important distinction to make, because that's unfortunately not what we're seeing in some of these non-clinical applications of psychedelics that we'll talk about in a little bit. But these integration sessions are with trained therapists, and then you do it again for 80 or ideally 120 milligrams. Ideally, the first one, particularly if someone's never used these substances before, is a good place to start. If they're able to go up to a higher dose, we do oftentimes see a dose-dependent effect in terms of efficacy. So for the people who feel like they are open to it, going up to 120 milligrams does produce a better effect than 80 milligrams if it's something that folks are open to. So for the second 2 rounds of this, where you do the session and then you have the integration sessions, ideally folks are going to go up to 120. And then there's the primary endpoint of the study. So another misconception I feel folks have about these substances is that it's like you take it and that's it. Like you have a psychedelic experience and then you gain all this insight and that's it. It's over. You move on. And that's actually not the paradigm. The paradigm is you work with trained therapists, you prepare for it, you have a ideally productive first session, you have 3 more sessions with therapists to continue the protocol and to talk about what occurred. And then you do that 2 more times with trained therapists over the course of 18 weeks. Which when I read about, when I see this and the buzz that you hear about it, I don't think accurately represents that. And that's really important too. I think that people oftentimes, again, when we're hearing about, like, say, single administration experiences or people taking ketamine at home, that's a very different kind of paradigm. So what we're going to talk about now is the MAPS protocol for MDMA assisted psychotherapy. Again, you can, if you just Google this, you can download it. MAPS is the, I would say, probably the leading society, what we'll call it, clinical and academic society on psychedelics right now in the country, if not the world. There certainly are others, but these are the folks who are really, more than others, in my opinion, really trying to push this from a scientific clinical trial side of things. Like, how do we standardize this and make this something that is part of medicine, say, as opposed to something that's more just public or recreational in nature. So, or even spiritual. Like, really, they're more about how do we make this something that's science related, while still being very open to the fact that this is, for many people, a very spiritual experience. So the general frame, though, to this type of psychotherapy is that it's non-directive. It has very humanistic roots and focuses a lot on empathic listening and focusing on participants' inner ability to heal. And if you choose to read this manual, you'll see this come up a lot. There's the it's based on the theory that our body naturally wants to heal itself. That just like if you get a cut, you don't have to tell your body, or you don't have to tell someone to, like, direct your skin to heal itself. The mind actually wants to heal itself as well. And if you put it in a situation where it can, it will do that. And so particularly in, say, administration sessions, the therapist's role is to not get in the way of what the brain is doing. I guess to kind of, again, use broad strokes. There's a lot of listening. There's a lot of, like, your brain's going to take you where it needs to go. You're going to have these experiences. And then how do we keep you with where your brain is taking you? And stick with that and let that do its thing and see what happens, because what happens is not predictable. And that's part of the nature of these experiences as well. It emphasizes mindfulness and presence with difficult emotions and thoughts. So, and again, so this is a protocol for PTSD specifically. And for those of you who work with trauma, you know that avoidance is part of the pathology, that people try to avoid cues that remind them of the traumatic event or people. There's a lot of avoidance, both of external things and internal things and thoughts. And so just like with other forms of therapy for PTSD, the idea here is that you are sticking with it. You are sticking with memories, you're sticking with feelings, you're sticking with the thoughts that arise, and allowing, and you'll see this in the manual a lot as well, allowing the medicine to work. That's a phrase that you'll see in some of like the sample dialogues that are included in there. Like, try to stay with it and let the medicine do its work, because as you stay with that stimulus, with that thought, with that feeling, the psychedelic aspect of that experience is going to change things. It's going to present it to you in different ways. It also, the idea here is also that you're going to invoke curiosity rather than judgment for reactions, thoughts, and feelings. So when people talk about something coming up within a psychedelic episode, you're going to be asking questions about, if you're having a dialogue at that point, for, I wonder why that's there. How do you feel? Like, what do you think about that? What's going on? Inquisitiveness and curiosity, exploration, but you're not necessarily interpreting much at all in this form of therapy, because you do not want to insert yourself necessarily into the person's experience. The other part that's critical to this is having two therapists in the room, one male and one female at all times, or at least most times, because this is a very vulnerable, someone's obviously extremely vulnerable in this state. And so from an abuse potential, from an ethical perspective, when these clinical studies are being done, there are two therapists in the room at all times. It does make a lot of sense. And again, if you choose to read the protocol, you'll read more about why. That being said, this also makes it very difficult to facilitate, potentially, like when you think about how does this scale? How might this be done at scale with people all over the country in a lot of different clinics when this lasts for 8 hours, that people are there? This is something that's probably going to cost a lot. And for insurances as well, they're not necessarily going to want to cover it, because just booking essentially 16 hours of therapist time to do one of these sessions is a lot, as well as for the preparatory sessions and integration sessions, because the trust needs to be there as well. Someone really you want them to go into these experiences feeling safe. So in terms of preparatory sessions, what goes on in here, people are discussing their goals, intentions, mindset, and expectations for the sessions. You're encouraging this attitude of curiosity and openness for the administration sessions. And then also really talking a lot about the process. So informed consent is stressed over and over and over, that people know what they're going into, that they're going to experience a range of emotions, from positive ones to potentially very negative, fearful ones, thoughts, potentially of physical sensations, emphasizing that they have personal choice and control over a lot of aspects of this process, at least in what surrounds them, what the therapist may do, what they won't do. And you want to increase those feelings of safety by reviewing the protocol and the strategies within it. So again, they're going to be very vulnerable. They really are. For a period of time, they're going to be sitting in a room with people they kind of just met, going through an experience that might be very challenging at times. And that is tough on any day for most people. And so really trying to help them feel safe and comfortable, control the things in the environment that you can, is a big part of what happens in the preparatory sessions. Another thing that you talk about in those sessions is physical touch. And this is another way that this type of therapy is very different than what we generally practice. So The boundaries around this are discussed with participants ahead of time, and they certainly can opt out if they just simply do not want to be touched, to be touched. But this is something that is very commonly done in these sessions as in a nurturing sort of way. Someone may be feeling extraordinarily scared. They may even reach out because they want to be held or comforted or to have that contact. And actually afterwards, because they will remember this, this isn't like a blackout. This is something that they're definitely going to remember and then talk about afterwards. They might really wish that you would have taken their hand, that you would have been there for them in that moment when they needed that sort of reassurance. And this, again, this is very different than what we do in other therapeutic contexts where we basically don't touch, certainly during sessions. I mean, some folks choose to give like hugs at the end, and not to say that that's unethical or anything, if you hug someone sometimes, but not usually during a session, right? We help people sit with it where we as therapists are not trained to touch. This is very different. There's also instances where you might actually do what's called focused body work during sessions, where if someone, say, for example, is like feeling like they're pushing against something or like pushing a block out of the way, what you can be trained to do is actually provide that pressure and push back against them so that they are physically acting out what they're experiencing in that psychedelic hallucinogenic moment. And that actually, again, leads to more profound like when we're talking about how do you enhance and give someone the best experience possible, there may be a moment where you want to apply pressure in some way, or you might want to push against them so that they can push. There may also be moments where they might fall off of where they're lying down, or they might be pushing against the couch. Like you can see in this photo here, and then this one is from Johns Hopkins. In their studies, you can see that there are two configurations that are recommended for when people are in. One is like this, where you have two therapists on one side of the couch, which is either against a wall or if it's a bed against the wall. And the upshot here is that if they are not wearing that mask, which sometimes they will, sometimes they won't, over the course of the period, that you can see both therapists, whereas otherwise you can kind of only see and talk to one at a time. There's pros and cons to both configurations if they go over in the manual. The other is where you've got someone not up against a wall, and generally in that case you have a therapist sitting on both sides. And again, it's very interesting to read the manual. I myself have not participated in a trial in any capacity, so this was actually my first window into what this actually looks like. But they talk about how there's pros and cons to both configurations, and that's something that you can choose, that some people may feel more comfortable if they can see both. Some people might like to be able to like nestle in the couch, for example. That could create a sensation that's helpful. At the same time, that also means that they can push very forcefully off against it, which could cause them to fall and to go onto the ground. So there's a lot to consider and a lot to plan for, and that's part of what you're looking at in these preparatory sessions. The physical setting is also something that very much feeds into the experience someone has as they go through this, and is something that's very thought about and controlled. So you do want it to be private and quiet. Ideally, you have the ability for them to either recline or to sit up. So a futon can be very helpful for this. You generally want to have a comfortable or living room vibe to the decor, not too sterile or medical in any way. Art supplies are usually available. If someone feels moved to express themselves in that way, you want to have that available to them. Music is also very commonly a part of the experience because it's a sensory integration where you can potentially evoke or catalyze an emotional state. So ideally, you want to have a soundtrack that goes everything from quiet or relaxing to very dramatic or evocative, depending on what they're going through. Instrumental is generally preferred, or if there's words, you don't want it to be in the same language that the person understands, because again, that can be suggestive in certain ways. And the whole, really the central tenet here is that you are not suggesting. The brain is causing certain thoughts and feelings to arise based on its natural ability to heal. You want to make sure, though, that the music enhances the experience and doesn't modify it. You also want to have medical equipment available so that if there is some sort of emergency, you can handle that. Some people, again, rare, do have poor reactions to it. However, that spike in blood pressure and heart rate is fairly common. So if there's something that you need for that, you want to have that handy. Ideally, you do want to have simple foods and fluids available, ideally with electrolytes, so that because people oftentimes do feel dehydrated, they do feel tired. So you want to make sure that they can keep their energy up to stay engaged in the process. And then again, the therapist positioning can be adapted depending on what folks want to do. Eye shades are also available. There are times where, I mentioned this in the next slide, you might encourage someone to go inside with a thought or an emotion versus talk about it. Again, with MDMA, folks can be more talkative, not always, but there's that energy. They might be more interactive than if they're taking psilocybin. And so there's certain times when they would want to talk with one therapist or the other, or talk about things as it's occurring. There are other times when someone might feel like stuck or confused, that it might be more beneficial to ask, how do you feel? It's always a suggestion. It's never directive, but how would you feel about going inside with this right now? Might that help? And if they say yes, then they put the shades on. The idea of consent and suggestion rather than direction while someone is going through this is really important, because again, they potentially are very vulnerable and potentially suggestible. So you don't want to be very directive. You really want to let the experience do the work. And if it seems like they could use something, you could present it in a way that's more of a suggestion. But if they say, no, I'd really like to keep talking about it, then that's what you do, because that's what they're asking for in the moment. So the structure of the sessions generally is you start with more calming music and relaxation, particularly if they're anxious. This is the first time someone has done it. It can be, there can be anxiety coming in. And again, you want that mindset to be as low on anxiety as possible to have the best outcome. The peak effects tend to happen about 70 to 90 minutes after administration for MDMA in particular, and then persist for 1 to 3 hours after that. So it can go on for quite a bit of time. If the participant hasn't spoken for about an hour, per the protocol, that's a good time to check in, make sure they're doing okay. The emotions and topics shift naturally throughout a session. So it's actually expected that it's going to go to those traumatic memories that they're there to work on, to gratitude, to connectivity, to positive mood, to trust. Again, there is a euphoric and positive feeling that most people who go through MDMA experience. So they oftentimes will get there. Those positive feelings, those feelings of connectivity, that is a normal part of the process. But the negative experiences are a part of that process for many people as well. You use verbal reflections on your part to encourage deeper self-reflection. And in many ways, it's very akin to the skills are very motivational interviewing, consistent, which also has humanistic roots. Again, the idea here is you are letting them forge their own path. I'd say even less directive than MI, because MI is more guiding, and this is a lot more following. But you're using those verbal reflections, those micro skills that you've learned to promote them to go deeper. So the therapist's role in these sessions is largely non-directive. It's based on that rapport that hopefully you formed in those first sessions, and that just empathic presence. I'm here for you, right? You might hold their hand if they're fearful, and be there for them. Your verbalizations are going to be empathic and present. They can suggest an intervention or direction, like, how do you feel about drawing that out? Or do you think a certain type of music might be helpful here? If they feel stuck for a prolonged period of time. It's not something, again, that you're just going to suggest. Like when you think about the pace of a normal therapy session, where you might, from your position, be thinking like, okay, like I'm hearing that this person is approaching this from a certain perspective. I'll ask if I can share mine, and then perhaps suggest another way to think about it, within 5 or 10 minutes. This would not be anywhere near that quick, because you really want to let them get there on their own if they can. But if it's for like 20 minutes, 30 minutes, an hour, where it just seems like they're very stuck, that might be where you would suggest that intervention or the direction yourself, rather than them making it there on their own. But again, largely, you don't want to get involved in directing. You want to let that happen. The phrase that's used is inner healing intelligence, where, again, it's the philosophy that the brain will do what it needs to do to heal, just like all parts of the body do that for themselves. You might suggest empathic listening or silence versus interaction. And generally, that's about 50-50 split. Of those 8 hours that someone's there, and particularly, in the middle of that administration of MDMA, about half the time they're not going to be talking, which again is very different than regular therapy of just sitting in silence and having that empathic presence while they are definitely experiencing things. And that's why they're not talking about it, is that they're having this inner psychedelic experience rather than sharing it with you. The healing process is guided by mechanisms from within their own psyche and in their body, and you want to help them stay present with that. So if they're having an unpleasant body sensation, like if, say, they're feeling the feeling of moving, like they want to move their muscles and it's hard to sit still, you'd actually encourage them to move around in the chair, to feel what they need to feel, to do whatever their body is telling them to do rather than to resist it. Or if they're feeling scared, instead of providing comforting or anything like that necessarily, you might hold their hand and say, let's stay with that fear. Or can you stay with that fear for a little bit longer? How do you feel about sticking with it for longer? I know it can be difficult, right? So being there, being present, showing them that they're not alone, but at the same time encouraging them to stick with it. Because it's kind of like the longer that's their focus, the more insight they're going to gain as the psychedelic impacts their experience of that emotion, of that feeling. So it's really very much you want to be out of the way of the process. You want to facilitate that process. You want to catalyze, you want to enhance that process as much as you can with your presence, with music, with art, with sensory deprivation, with a eye shade, if that's what they need in that moment. But you just want to magnify what they're experiencing, but not direct it. You also, in the moment, might want to support expressions of beliefs that you may not personally subscribe to. Like, for example, it can be very common for people to talk about multiplicity of self. So talking about different parts of themselves as if they're people or sub-personalities or a regression to an earlier state of their life. That might not be something you subscribe to, but in that moment, you want to help them go there. Like if that's where they're going, if that's how they're talking about it, tell me about this other self. Tell me about, okay, you're a child, right? What's that like for you? Or transpersonal experiences. So if they're saying they're having memories that didn't happen in their life, but happened in somebody else's, or if they're having a spiritual experience from a faith that you might not believe in, or if they're talking about memories of being in the womb, like those are things that you might not believe in, which is absolutely your right as an individual, just as it's their right as an individual for that experience to be very real for them and might be what they believe. And so really drawing on that training that we have of not putting our beliefs onto the people we're working with, and to really support and enhance wherever it is that they go. So in terms of the follow-up sessions after this experience, the first one you actually do 90 minutes after the day after the treatment session. So they go home, they have a night to think on their own about it, and then they come back in the next day. You want to take a very validating and supportive stance about what they're going through. And the purpose of these sessions is to explore the new insights, perspectives, the shifts in the relationship with their thoughts and emotions, because ultimately that's what they're here for, right? They want to shift their perspective on the past or their ability to deal, why they're depressed, or even like perhaps a feeling they're having. Say they always are just feeling so tired and down and worthless. Perhaps in their psychedelic episode, their worthlessness was personified and was a person, and they had a conversation with it, right? And so talking about what that conversation was like, or what it was like to have their depression be like a person that they were talking to and not them, perhaps a part of them, but not. So those are the sorts of things in the integration sessions. Whatever comes up is what you're discussing. You're discussing, also potentially talking about the next one, the next step, but exploring meanings and implications, keeping focused on the participants' judgments, not the therapists, encouraging this further reflection in their daily life. So these times, oftentimes, they can be very profound, and that's good. You want them to be profound and to reflect on it between these two administration sections. And then normalize also waves of insights. That's something that oftentimes happens for folks. So as they think through and process what they went through, they may have more insights a day, 2, 3 later, where it comes very quickly. And then you talk about that again in the next session that you have. So that's the protocol. Again, there are a lot of pages in there. I obviously, we're not going to read it together here in the training, but that was the best that I could do to really try to sum up the vibe and the approach and this general structure of what folks go through with it. And again, the good news is that it really seems to work quite well. This is this is what it was used for. So this was the trial that used that protocol. And you can see here that there was the baseline of people who started the same place between just a placebo with therapy and then that MDMA-assisted therapy. And you can see that both folks got better, but the MDMA-assisted therapy actually helped quite a bit.